started. Everybody can find your seat, please. Let's get started. I believe we have 4 tonight. Welcome, everyone. And I'd like to call the meeting to order. At this time, I'd like to call on Bill Nolan from Haywood County to lead us in prayer. Bill?
Let us pray. O God, our liberation and peace, we seek the power of your Spirit, that we may live a fuller union with you, ourselves, and our sisters and brothers with mental illness. May our acts and decisions lead us to overcome fear, acquire knowledge, and be advocates for compassion and enlightened treatment and service. May we go forward into our community with a renewed sense of vision, hope, and new beginnings for the future. Amen.
Thank you. Next item on the agenda is the approval of the agenda. Has everyone had a chance to review the agenda? And if so, is there a motion to approve the agenda? So moved. Larry Knox approved. Billy Kennedy, second. All in favor of approving the agenda, say aye. Aye. Opposed? Public comment. Do you have anyone signed up for public comment? Go ahead.
I'm Kathy Ryder. You've been talking about expanding to an entity that will cover 35 counties. I'm concerned about system-wide problems that will be made worse with that expansion and with the loss of personal attention. Despite the earlier report on meeting 100% of standards, there needs to be some way that this big organization can find and track and help those who are falling through the cracks. For example, that young man who's made 2 suicide attempts but isn't getting good follow-up care by smoking. That child living in a dangerous situation who can't get the results of her psychological report because a provider can't get paid by smoking. That youngster I mentioned last month, whose increase in aggressive behaviors puts him and his family at danger. Did you see the report about the senator in Virginia whose son snapped, stabbed, almost killed him, and then killed himself? Okay. It's not a far stretch. I want to give you an update on this fellow. Mentor told mom they weren't able to serve her son. I'm sorry, RHA, but RHA said their caseload is full. They'd be available in a few months. Unfortunately, he ended up in the ER. As a result, RHA is now the de facto provider. They're responsible for finding interventions and residential placement. They've promised therapy, hasn't been forthcoming. They've been doing a fading plan of in-home support, and they sent a letter of discharge because they hadn't seen this stuff. There's a disconnect here. I'm wondering, you're expanding pretty fast. That loss of personal attention is of a concern to me as a parent of a person on the waiver and a child with a mental illness. My experience is that many times professional blames parents for the children's problems. I've been told a lot of times that if I was a better parent and more nurturing and more this and that, my kids would do better. That's not always the case. The players in this particular young man include the public school system. Between 2002 and 2013, here's a binder with his IEPs. They've had 15 assessments and they still are not giving effective instruction. More materials, mom's working at home, design stuff. I, who am a teacher, do not do the level of work that she, who is not a high school graduate, does for her kid. Psychologists, doctors, and adjunct services, 22 assessments since 2002 and 2013. 22. That's an impressive number. Provider agencies contracting with Western Highlands haven't been accountable. Granted, you're not Western Highlands until October. This is a big system with pieces that fall apart. Universal Health in 2006 did an intake. After they sat and were told they'll get therapy, his insurance didn't cover him. The kid wanted help, didn't get it. They tried again in 2007. After 40 days, they finally called and said, we lost the paperwork. We need to try again. We got to hold people accountable. Turning Point did 3 years' worth of developmental therapies, decided it didn't work, and suggested intensive in-home. Family Preservation Services in 2011 did 6 months, multiple visits, multiple people. Time's up, no report, no transition. Drop the ball. Where's the accountability? Another team player are the police, who've been called to the house a number of times between 2011 and 2012, including 2 ER visits unsuccessful for psychiatric hospitalizations. Between 2011 and 2012, mobile crisis sometimes came when it was called and sometimes it didn't. They often referred the family to the police. In 2012, DSS, investigated self-harm. This kid's hurting himself. They recommended therapeutic placement, closed the case. The silos aren't talking to each other. We've got school, we've got DSS, we've got providers. They're not talking to each other. As you plan to expand, please keep in mind how hard it can be for parents to find the right help. This mom made a good faith effort. 30 evaluations, and her kid, but for the grace of God, and hopefully Smokey helps soon, isn't going to hurt people. Here's the medication list they've tried, okay? All I can do in my little blurb is remind you that there are people here whose lives depend on what it is that you do. Thank you.
Mary Short.
Hi, Mary Short, Taylorsville, Alexander County, and Katie, who just has a great time listening to you all cough and sneeze. That's her always laughing. That's why she's laughing. Okay. So we sat here through the executive committee meeting, but we were also in Raleigh for the Health and Human Services Oversight Committee meeting, and we were also in Raleigh for the Division Waiver Advisory Committee meeting. And we had the opportunity to listen to Mr. Bob Atlas and Ms. Marty Peel as they talked about Medicaid reform. I also, let's see, I haven't seen you all since I was at the December Alliance Board of Directors meeting. And then also there was a meeting called Money Follows the Person that Katie and I attended. Marty Peel also spoke at that. Every time I hear Mr. Atlas, who by the way is not a member of the governor's 5-person panel for Medicaid reform, he'll be the person, I guess, he and Marty presenting the plan to the General Assembly from that 5-person panel. Every time I hear Mr. Atlas speak, he talks over and over and over again about these new entities, this new Medicaid reform, being at risk. Now, we all know that when the MCOs were proposed to go statewide, it almost fell apart when the counties realized they were going to be at risk. And the bill was changed so that the sales tax was, I guess, given back a swap to the state. But every time Mr. Atlas talks about what this Medicaid reform is going to mean, he talks about it being at risk. I also had a chance to talk to Marty Peel for just a second about this idea of regionalizing all of Medicaid. And I was able to tell her that so far, the IDD population is the only Medicaid population that is regionalized, meaning we cannot move. We are forced to have services where we live. And I sort of brought it around to her in terms of, well, Medicare isn't regionalized. I can't imagine why you would want to regionalize Medicaid. Just something out there. And then also earlier today, in the executive committee, there was a statistic given about complaints and grievances, and no one on the executive committee asked any follow-up question, but the statistic was that 91% of the complaints and grievances were handled within 30 days. Aren't you curious what handled means? Wouldn't you want to ask a question? What does handled mean? If I called up and made a grievance, or if the provider called up and made a grievance, or if, I mean, well, we handled it in 30 days. See you next month. I mean, it was just sort of sad to sit here and not see anybody ask a question, which is what we do every month, sit here and watch nobody ask any questions. Anyway, see you next month. Wait. That 5-person Medicaid reform group, the two doctors, Peggy Terhune, Representative Dollar, Senator Pate, their first meeting is December 5th in the Brown Building at the Dick Center, 10 a.m. The January meeting, somewhere in the first 10 days of the month, is going to be public comment. Thank you.
Thank you. Gary Ross.
Thank you, Mr. Chairman and members of the board. Appreciate it. Instead of the senator's son that died, I'd like to bring it closer to home. In the past week, I have been acquainted with 3 families that have committed suicide in the adult here in Buncombe County. 3. Now, the newspaper don't print it. We don't hear it here. So where's the numbers at? Mental health reform has took its place, and we're getting good numbers in reviews here because of it's not being reported. Now when I say it's not being reported, yous are reporting numbers, but the state reports the numbers, other people report the numbers, but the real number of people that's suffering, yous are only handling part of it. There's no way that we are looking at the full picture of North Carolina and the needs of people with all kinds of mental health issues. We're only looking at a segment, and the counties are having to deal with the rest. If you go back to 2001 and look at suicide rate in the teenagers and other people, not in the Medicaid world, but look at the real picture, you're not touching the surface. Now, how do we improve this? Who are we not reaching? I'm going to keep repeating it like a mockingbird. I'm going to keep pecking at this thing. I deal with school issues with kids with special needs. There's a program and a federal law that's called Child Fine Law under IDEA. That's where you need to be looking. In 2006, there was something that connected mental health to the schools, but it's since been done away with. Schools are resistant to having mental health and any kind of else programs in their school system because they do not want the second set of eyes in there. There's a lot of things going on that they do not want anybody to see. I'll speak to that from my point of view because I've been in Buncombe County for 62 years and I've been doing this 26 years, and I can tell you some stories. Just this week, I have had 2 families with autistic children, one 7 years old, and one 11 years old, put into the juvenile court system because of assault on a teacher, for biting or kicking a teacher. Good God. What a crime. Now, I'm giving you just a short little synopsis of a bigger problem. If you can deal with the school system in some way and coordinate, which you ain't got but 2 people in your system that is going out and educating people that I know of, and trying to get education into that. But if you can get into the school system in a way that you start on that end of it, what's going to happen is you're going to cut the school to prison pipeline. You're working on the wrong end. You're working with people that's already diagnosed and already whatever. There's a lot of diagnosed people that these people are referring to here that I've worked closely with over the years, that they're not getting your services because they've done give up on you. And I'm not talking about personal. I'm talking about agencies. They have done give up on you. They went home and they're committing suicide, and those numbers are not being given to you all because they're out of the system. So the state law on moratorium, on restraint, these two kids that I'm talking about was restrained in the school system by law enforcement, handcuffed, put on the floor. Now, I am concerned about this because we are going to deal with this later. And it's going to be sooner than later. So I'm giving you a picture, I think, and I wish somebody, Brian, I wish you would contact me with somebody in your group, and I've done asked this. I want to talk to somebody in your group that can help me to look at the school system in all the counties, because you're losing a big piece of what you're required to do. Thank you.
Thank you. Go back to Garland.
My name is Rebecca Garland, and I'm a resident of Cherokee County. I have a 24-year-old son with an intellectual disability. I don't hold any degrees in mental health, substance abuse, or IDD, but I do have a degree that I feel qualifies me to speak to issues related to the IDD population. I have an MOM degree, MOM. My family has been served in some capacity by Smoky Mountain Center for most of my son's life. I want to first tell you a success story because of the services he has received via North Carolina Innovations, formerly known as CAP-MRDD. With an IQ of 34, because of good paid supports, a mom who would not take no for an answer, and a great post-secondary education program at Western Carolina University, he now has a job in his community making a competitive wage much higher than the $25 a week he was making in a sheltered workshop. And he is planning to continue to live independently in his community for the rest of his life. He's happy, he's healthy, and he's adding back to the community by working for EMS as a custodian, where he is well loved, well respected, and well appreciated by his co-workers. He's continuing his education, his post-secondary education at the local community college, and he actively volunteers in his community with various nonprofits to give back. He has a meaningful life. This will continue to be possible as long as he's able to maintain high-quality paid supports and maintain an appropriate level of service through North Carolina Innovations. Because he's working in a community job with support via supported employment hours, not in a sheltered workshop setting, and choosing to maintain a community housing placement, not a group home or an AFL, he is actually saving the state of North Carolina approximately $100,000 annually in Medicaid funding. That is the good news. Now here's the bad news. About 40 years ago, as we all know, the state began the process of deinstitutionalization. We've come a long way, but not near far enough. Too many persons in the IDD population are still in some form of institutionalized care. Day programs and workshop settings for vocational opportunities should have been a stepping stone to community settings, but it seems that we have gotten stuck in that model. Kids are educated in inclusive settings only to be told at high school graduation that their only option, their only choice is a workshop and a group home setting. They lose touch with their non-disabled peers they've known since kindergarten, and their world begins to contract. They lose social skills, and they lose meaning to their life. North Carolina Innovations has made a difference, but it's not enough. There are far too many persons in North Carolina, in our area, on waiting lists. I know one young man who has been waiting for 7 years for a slot. I know paid supports who are motivated and qualified to provide support, but who are being informed by providers that they will be getting pay cuts and will be getting and be making substandard wages. Most of these cuts are coming in the personal care and respite areas. These are areas where some of the most intensive care is provided, and respite seems to be the first area that gets cut when hours are being negotiated at care plan meetings. Families need respite in order to maintain the consumer in the family setting. It's difficult to recruit solid, dependable workers who are motivated to keep their client, or help their client become more independent when they are making less than competitive wages. We hear as families through the grapevine that more slots will soon open with the merger with Western Highlands, and I hope that this is the case. But it's also distressing to hear that our voice may get diluted with the merger. The counties of Cherokee, Clay, Swain, and Graham in the west have no representation via our county commission. Our closest voice will be coming from Jackson and Macon counties, so I urge those commissioners and managers from Jackson and Macon to stay in close contact with your sister counties to know their needs. The farther west you travel, the less resources we have to make independent community living a reality. I urge you board members not to take on a groupthink mentality. Do not allow yourselves to be spoon-fed information without diving deep into the issues at hand. Don't make decisions when you don't know all the facts. This board should not be political, and decisions should be made for the best interest of the consumer, not the best interest of the board or of the MCO. Remember, your position on this board is a fiduciary responsibility. You're responsible to see that your constituents are heard. Get on the ground and visit workshops and group homes when you are not expected, and hold public forums in your area to see what the true needs are for the most vulnerable in our society. Those you serve may not be able to speak up for themselves, so you should be the voice of progress. I am but one voice, but I assure you I represent many voices. Your mission is to be a regional organization serving all in that region, to coordinate high-quality support to persons with IDD, and high quality comes from paying a competitive living wage to high-quality workers. Being effective in human services is all about resource allocation in a climate of scarcity. I get that. I'm a county finance officer. But let's not lose sight of the goal. Persons with IDD getting less than adequate support for community living and being warehoused is not the answer. Please remember these things when you make decisions that directly impact the most vulnerable in our population. Thank you.
Thank you. The next item on the agenda is the Consumer and Family Advisory Committee report. Pat?
Thank you. CFAC's pleased to be represented here, and all four regions met by video November the 19th, which was our very first meeting of all four of the new regions consolidated. CFAC heard a presentation from the needs assessment consultants, and also heard about recent legislative changes from Allison Luke concerning the Office of Administrative Hearings appeal process, guardianship, and the transition to community living. The CFAC Steering Committee will meet with all four regions for the first time on December the 9th. The meet and greet, of course, took place October the 19th, and it was a success. Went well, and it was a beautiful place. We have to go back there. Members continue to be involved on committees and cross-functional teams. The Provider Council, the state and local CFAC call, as well as activities in the community. And a couple of us went to the recovery conference last week, and it was really, really nice. Met a young man who told me that about 30 years ago, Christina was his case manager, and that she had probably done more for him than any case manager he had ever had. And then the really great thing for me was he stood up later in a different meeting and said that he thought it was the greatest day in his life, just the fact that he had made it and was able to be at that conference. So, you know, people do want to be involved in it, and it's really special when you meet somebody like him and they stand up and they tell you what it means for them just to be at the table. So I was really pleased to witness that. In January, each of our regional CFACs will hold their local meetings. The Central Region will be the 13th, the Western Region will be the 14th, the Northern Region the 21st, and the Southern Region the 28th. Thank you.
Thank you, Pat. Under Board of Directors items, the only thing under board chair issues, Mr. Yen first, December 11th through 13th. And as it stands right now, our next meeting is December 19th. So our board will be December 19th. Under standing review, under item 2, there are no conflicts. Under the executive committee report, the executive committee did meet earlier today. Brian is going to go over several of those items under the CEO report. So at this time, we need to go into closed session. And need a motion for the closed session.
So moved, diligently.
Is there a second? All in favor of going into closed session, raise your right hand. Opposed? Unanimous? Okay. Let's get started. The next item on the agenda that we have under board of directors items, it's the Smc-Whn Western Highlands Reconstituted Board. Just an update. 14 counties so far have approved the nominations, and 1 county has voted against it. That's where we stand at this time. Our next item is the CEO report. Brian?
Okay, let me just add that I know people are very curious about whether the secretary has signed the merger agreement yet, and there was some indication that that was an agenda item today for an internal meeting at DHHS, and I haven't got any feedback yet around the status of that. There's no reason for her to not sign it, of course.
But she hasn't signed
Did
it
you hear anything about that?
So the 30 days will not start to roll until she signs it. See, I would assume that she would have signed it, assuming that she was going to sign it, what, 2 weeks ago, right?
Something like that.
But she's not signed it as of yet.
For today.
No indication. I'm glad we delayed our vote in that.
No indication why.
Just didn't get that far in the pile, I mean, really. It's
So when are you expecting her to vote then? When are you expecting her to sign it?
today.
Today.
You know, again, I just keep calling and I say keep calling. And that's probably not quite fair.
Will you notify us as
Oh,
soon
yeah.
as that is signed?
And again, there is no, she's not delaying it for some reason. I think it's just, getting it done. Just,
And will y'all let us know by email when that happens?
I'm gonna send out smoke signals. It'd be like a cold, right, when they do that?
White smoke, exactly.
We'll do something like that. Regionalization and MCOs. Pretty lengthy discussion this afternoon at the executive committee. And where we started with this was with this one-page handout. And I would, oops, that's a different one. Did we include that for the full board? It's in there somewhere, I just skipped over it. We should have a piece of paper. Let's see what it looks like.
It's got the 3.
This. So just take a minute, and what I would ask is that you find it. And if you don't have it, we'll make sure you get it. Locked in your file somehow, and then take a couple of minutes and read through that, and we just kind of talk about that. This is just a single piece of paper explanation of what we're doing and why. This has been used for staff meetings and a little bit public. questions do you have? Let's start with that.
So it's happening in two sections are related, so, will there be an order of two merging and then merging with the third? Or is that gonna make a difference on, control, two merge and then they bigger than the other one?
Well, that's not really what is meant by that. What we're trying to say there is that, one part of this is the operational effort and the organizational effort. Operationally, think of it like this. That's how I describe it to staff. Very similar to how we work with Western, where we look at a large number of business operations. We do a discovery process. How do we do this? How do we operate our call center? How do we do credentialing? And we'll use credentialing as an example I used this afternoon in the executive committee. Process whereby we basically review credentials and suitability of licensed providers to be providers we want to contract with, and often that's individuals. How does Smokey do it? How does CenterPoint do it? How does Partners do it? Is somebody doing it really well? If so, does everybody want to do it that way? A large part of this is standardize these business processes. One of the challenges is that, we came on 7 months before both of these programs did. We're at a different place. People think differently. There's parameters for these things to be alike at the end of the day, but how you do it, there's some room in there. So looking at that. Okay, so in this particular case, we could have decided, well, there's one good way that one of us is doing it. And in this instance, it happens to be a legacy Western Highland approach that we borrowed when Western and Smoky came together. Well, Partners in CenterPoint are so satisfied with that process, they're saying, we don't even want to do it. It doesn't make any sense for us to do it. We should just contract with you to do it. So there's one outcome that they're getting, right? Makes sense? Versus other areas that are just much more complex and, we have to all keep doing our own thing, so to speak, but over time we'll come closer together around how we do it. And again, it is very, in that regard, very similar to what happened with Western, where you're just looking at business processes and creating the best possible way of doing things. And again, with this process, the difference being two other organizations and adopting versus contracting and whatnot. So it's a lot of that. That's the operational effort. Standardization, efficiency, discovery, next steps. Organizational effort, at some point, we're talking about having one organization. Okay? Now, what does that mean? One CEO, one board, one everything. Okay? And it's probably worth it to, and you can just imagine all the elements that would be associated with that. And all the disclaimers in here about that, because that's of course where people go to with this. So let's think about that. What does the timeline around all of this look like? I'd really ask you to kind of hang with this because there's a bunch of steps, and this will be something important for you to, we'll talk, this will be one we need to be talking about this every month. What are the things we know? And whether you care about this in relationship to all that's going to have to happen to Smokey, and what the future is, the relationship, and so much discussion about this with the board, because this puts us over the magic 1.2. Not that, I think there's a good chance, I'm going to say, Connie's not here, but, in the session, because this is going to go on, is there going to be some attention paid to hold board governance again? I think there's a good chance of that, because everybody knows this is coming, right? But when is it coming? On March 17th, according to the general statute, the secretary has to release her Medicaid plan, her Medicaid reform plan. In the spring, there was this big announcement, just made everybody crazy. You know, talking about a very, very significantly different approach than what the state had been doing. It was about a 7 or 8 page PowerPoint and no details about how, you know, what was it really going to be, and how are we going to get from where we are now to there. A lot of anxiety. Well, this will have to provide a lot more substance to that. Then in May, June, and some part of July, the General Assembly is going to make some sausage, as we like to say, right? They have the authority to approve that plan. And they wrote that into legislation. So they're going to do what? Would anyone like to take a guess? I mean, you know, I'm not being facetious. Really, what will they do? There's also a panel, and you heard some comment about that, that's beginning to meet. In July, everybody gets sick and tired and goes home. Okay, the session's over. Are we going to have an approval by the General Assembly for the state to go ahead with a plan that would likely involve a different type of waiver? We certainly could. That will be a goal. We have a lot of people. So how long would it take for the state to complete an application? And again, we're just going to kind of create reality. Let's say that's going to be an 11-15 waiver, which is different than the waiver we have now, which is 1950. What do you need to know about that difference? Well, that's a demonstration and research waiver. The standards for how that is put together and approved are very different from what we have now. It's a lot bigger deal. So, could it take a long time to write? It could if they put a lot of special stuff in there. Could it take a shorter time to write if the state hires consultants that have already done it for another state? And this waiver looks a lot like ones for other states? Yeah, it could take a lot less time. So what's the range of time? Well, 2 months to a year. Is there going to be pressure to get it done faster rather than slower? Yes, there is. But again, I'm going to give you the whole picture. So could it be by the first of the year that waiver's done? It could be. Or it could be the first of another year. Then it goes to CMS and it has to be approved. And again, because it's an 11-15 waiver, we're going to assume that the standards for approving it, because it's an idea that a state is testing, as opposed to the 1915 BC, which is a lot of boilerplate. Right? The complexity of it, how different it is. Again, we're into a wide range of how long it's going to take CMS to approve that. Is that months or is it a year? Then, once that approval occurs, the state would then be in a position to do what the Secretary talked about doing in the spring. We're going to have this integrated approach to managing Medicare, Medicaid, and we're going to do that in the form of these comprehensive care entities, and that there would be an RFP process for selecting those. Well, so where have we gotten to in the timeline for what Smokey in this western region has to do? We're probably somewhere between July 2015 and July 2016, where we would need to have an entity that would be able to, and I guess the term I used earlier with, to be able to play in this new sandbox. The price of admission is going from 10 down to 4. That's it in a nutshell.
So on the operational side, do you think there'll be savings by using whichever system seems to work best for the three? Because this is a different case in that all three of these, none of them have had their Medicaid waiver pulled. So it's not the distress situation or that force situation that Western Highlands had.
Right.
So really you're looking among three equals, and none of them are really failing. So each of them surely have some things that are a little better.
Correct.
Duplication of services, so
Right.
you'll get some savings on economy of scale.
Correct.
And then on it, but you'll still have to have the staff to handle all those cases. So it won't be a huge reduction there. You might gain some here or there. Well, I don't know how their finances are, so I can't say. And then on the organizational side, I would say that might be a place, and I don't know, once again, whether, I guess I'd like to assume that the administration is skeleton staff enough so that it's not too much fat padded in there on all of these organizations. And that somehow, I guess, some would leave, but some would stay and then merge ideally in a long range towards one organization. But, and they're interested, I guess, in feeling it out too, because they are in the same situation as us. They're going to be smaller. If they don't become one of the big fish, they're going to be gobbled up. So.
Well, the approach of the region, again, if you look at the word, is to create a new entity from the three.
Good luck.
So how I explained this afternoon, you got 100 counties in North Carolina. Let's say you had to name 4. Sound like fun? We could spend a lot more time talking about this. It's very, very serious, substantial.
And this is taking, I mean, like you said, the research and the study of this, these meetings, that's time y'all are not spending on other things. So are y'all figuring in enough, I mean, this is almost like a whole other job in and of itself, and we've been dealing with it for 1 year, and we're looking at 1, 2, 3, possibly 3 more years of this. Are y'all adding staff for that, or how are you, we don't want your staff to burn out, we got good staff here, we don't want to kill them on this, but how's that working out?
How's it working out? Well, our approach to that is we try to absorb the workload as best we can. And we have used consultants. For example, we have the Chancellor Collaborative, Lanier and Tara, and they've actually added a person to help with this effort. So they've been engaged in this western region. So, they do a lot. It's been a lot of work for us, yeah, it's a lot of work for us. The point about administration and efficiency and savings, look at our experience with Western. We probably we have extra staff to do that. I know, okay, but you gotta appreciate, you go through a transition phase, you go through a startup phase, you go through a closeout phase. That's all new work.
On top of everything else you got to do.
So it's not like you end up with less, you end up with less in the future. Okay, once that whole bubble, right?
Yeah.
So it's not like, I know the popular thinking is, oh boy, you'll be able to just reduce staff and save money. Yeah, after a while you will.
Some, not that much. I mean, if all these organizations are somewhat efficient, you'll get some economy of scale, but that's just part of it. I mean,
Yeah.
as long as we're serving the needs of the people.
For example, what we found is that in the Western situation, as we've gone and negotiated a new rate, well, they've reduced the rate on it. So there's less money. Because they're sucking it out, whether you want to or not. Sure.
Well, since I've become a member of this board, we really only dealt with this merger and board composition situation. Most of it. I guess now would be if we got an opportunity or something about another merger and piggyback on what real estate policy. And I listened to these concerns from the public. So I guess now's a good time. What is the process for addressing these concerns that we hear? I mean, they take the time to come, and you hear these. What's the current process? And then what will that look like when this organization grows larger and larger and larger, and more people fall through those cracks from such a large organization?
I don't
Start with
know
the
if I
process
started
now.
answering your question. Is this it's almost, part of what the question it begs is this a good idea? I mean, Ed, is that kind of underneath
Well,
really what
that's
you're
kind of-
asking?
How big do you get, and of course, the whole point is providing the services, that's needed. And how is this gonna affect those services in light of course, I've heard a number of people since I've been coming, I think this will probably be my 6th meeting. And, so I'm hearing some concerns of people falling through the cracks, not making it to those services needed. So, well, like I say, what's the current process? When does these concerns that are asked in this meeting get addressed? Who follows up on that? When does that happen?
Normally what we do is when we have a break is talk to folks and, figure out how to engage with them and address things. And a lot of these things are, there's a lot that's happened already. We just do not respond to public comment.
Oh, yeah,
Turn into something.
Yeah, I'll agree with that. I understand. So
So
there's a process for following up with what you're,
we just don't talk to people. I mean, in many cases, there's a lot of conversation already going on in relationship to these things. So there's that. Are we doing this because we think this is a good idea? Kind of. It's everybody at LOC, I forget who it was, talked about the voluntary nature of this regionalization. Well, is this voluntary?
doesn't feel like.
I guess it depends on, your definition of voluntary. This is the argument, I don't mean argument in a way about conflict, but how I describe much of what Smokey does. We're the implementers of public policy. My job is to get the best outcome for the cards we're dealt. Try to, manage the cards that get dealt as much as possible, but at the end of the day, we're going to get some cards and we're going to do the best we can with them. And this is what we need to do and make the best of it. Are people going to get, lost in the cracks? Every system I've ever worked in has that feature. What you try to do is minimize it, and when it's found, deal with it as appropriately as you can. There won't be anything different about that with the organization, no matter how big it gets. And the next question, that comes out of this is, how big is too big? How do you manage having a local presence and all of that? I mean, that's what's embedded in all of what you're saying. And that's why this is such an important thing for us to discuss. I mean, I have my answers to that and what I think about this, and I'm one of 3, okay? Nobody's decided it's what Brian thinks about this, okay? But I know what I think is the right way for this to go in relationship to that. And I mean, it's just a matter of time, how much, we want to get into that discussion, but I think there's very real pieces of what we do that need to be preserved regardless of what size we are. That are the things that are important to consumers and families and providers and people that represent counties and all of that. We're no different than you, really. If you follow me, I mean, those are all the things we care about. This is what I've done for a part of my life. Care about the same things, doing it right for people. And regardless of the size, there's different challenges in terms of doing that. Care coordination, community collaboration, and local presence of providers, just to be real quick about it. Those are the things we have to maintain. It's, you've asked some good questions that deserve a lot more discussion. But I think for the sake of time, I can go on a long time. I have a lot of thoughts.
Brian, is it true where we're at, Mr. Williams? The legislature's going to have to decide, maybe they'll do that through, so what is North Carolina going to do? All right. Then if you look at our part, I think that we should be considered way out front with our consolidation. If we've got 1/4 of the state, we ought to be setting the pace for them, and the other people just copy us. seems to me like a lot of the work's done. So let's say that we're gonna have 4 MCOs. Western region, you're one of them. Then there'll be 3 more from everywhere, Paris, Lee, and stuff. Then we've already done the groundwork, it seems to me, how you do it. Is that true? Is that where we're at? Is that?
Not, you know, is the groundwork done? No, not really. You know, there are elements, and I think Billy, you know, mentioned it, elements like the Western situation, except this is not, you know, with all due respect to the folks from Western, that was a contract termination. Nobody's having a contract terminated here. That's the voluntary part of it, okay? So it's a different this is a really big process. You know, at the end of the day, this ends up being a $750 million company, okay? Yeah. 35 counties of the state. And while we understand the process, and in fact, for folks that are, you know, are newer to Smokey, we're an amalgam of 3 area programs and now 4. And all of those have been a result of mergers. Okay? So yeah, we've done all of this before. We're the only ones that have done it under the waiver. In a, what was your term? In a, not drastic, in a, I used a good word. What was it?
About how it went together?
You know, with, you know, in terms of Western and a termination.
That was a duress situation.
Duress, right, a situation of duress. I think that's a good choice of terms. This is different. These are healthy, you know, organizations that have, you know, differences and trying to figure out how to create a region. Are we ahead of the pack? Yeah. You know, this Western region effort is ahead of the other regions that are also trying to do this. Partnership for the Future, Status of Transition Activity. Boy, this is anticlimactic. We're talking about 23 counties. Okay. Well, you know, I was talking to Christina about what should be the items we really talk about here, because it's, you know, the major stuff is, I would say, done. You know, the things that you think of as these major milestones that you're, you know, how we used to come to the board meeting both here in Western and say, wow, you know, check. Staff, hiring, flipping the switch out, you know, check, check, check. Now it's the very important things about business processes that are being refined and really solidifying the operation around it being one core organization. They're really getting tighter and tighter and tighter around how we do business. Christina, you can probably describe some of that better than I can.
Good evening, everyone. Well, I just counted up it from October 1st to today, we're 52 days into being one organization. And we have to really remember that. And I'm one that kind of says this a lot, because even though we've been in transition, we've been consolidating these 2 entities, you know, since April something, it feels like we've been doing it for a long time. And when I look around the room and I look at the senior staff and Dr. Martin, our chief medical officer, and various people in the staff, well, we're settling in. You know, we hired 156 people. People are beginning to understand their department, trying to settle into their jobs, their job descriptions. You know, we're still making sure people have an office, a phone, a computer, and technology works. We've made decisions to put more video equipment in McDowell County, because we've created more additional office there with Jenny and some of her staff and care coordination on. You know, we're looking at just how do we settle in. One of the biggest things when you think about a merger, many of you probably had your own experience about this, is just getting the cultures together, the mindset together. There's always a sense of urgency in this business, getting people to understand that. But where do you go to work? How do you do your job? Who do you report to? Really instilling our values and our missions. I mean, there's just the day-to-day work. My word I say a lot, which I don't think is a bad word, is that we're kind of clunky. We're still kind of getting together, settling in, figuring out where people I think we're doing more than just going to work and doing the job. I think we're really, because the system demands accountability immediately. We're settling in with our contracts with our providers. We, you've heard me say before that, as you heard Pat talk about our CFACs, we had a historical meeting this week where all the CFACs, who have been with Western Highlands. I'm sitting in Asheville and I'm looking at, the people in that room, and 3 or 4 people on the video screens, and I'm like, wow, this is a special moment. We have our council, our provider council, who's trying to solidify that. Sandy from RHA and different people are part of solidifying the bylaws to that. So a lot of foundation is in place, but we continue to build that foundation every single day. I think we're also, to be really honest, still meeting, a lot of new partners. We're getting to know all the new DSS directors. Do we know them? Yes, we have. But now we're knowing them around cases and crisis and situations around children and families. I'm thinking about when Jerry talks about the schools. We've been very involved with some school issues recently. So there's a lot of detail within each every department. Look at Carla here, who is our new senior director for the call center, and getting that call center 24/7, 365 up and going. But in the same breath, Carla and some of her staff, we went to Elton, North Carolina, and visited the Partners Call Center a couple of weeks ago. You know what I'm saying? Lisa, you may be planning to do this, but maybe you want to introduce your new board.
Yeah, I'd love to.
Okay.
Will, thank you. This is Will Grant, you Senior Director of Finance. Will's been with us about a week and a half and has, I guess, around 20-plus years in hospitals. And Lynn, you may recognize him. He was in the Appalachian Regional Healthcare System for a number of years. But we're so pleased to have him and his hospital expertise that he brings to Smoky Mountain.
Christina?
Yes.
I didn't mean to interrupt you. I know it's work and it's hard and y'all got to take a lot on your plate, but sometimes a challenge is fun. And this is really kind of remaking an organization. You get kind of sometimes bored and the same thing, and it's a challenge. So I'm waiting for that. Well, I hope it comes off as some positive instead of all this extra.
I do think that, God knows, y'all have been so gracious of the board to be so grateful to all of us at Smoky. And I say every time Brian and I, we just be around and enforce staff meetings and get around to every employee in 4 different locations in 23 counties. So that's a statement in itself. When I came to Smoky 3.5 years ago, I could have everybody with Silva in the board, and that's pretty interesting. But, I will say, even though we may all work crazy hours and we probably get really tired some days, there is an energy to this, because as much as it truly touches, I know, all Smoky people's hearts and this board's heart, with the people who drive, wherever they drive from, to come tell these stories. That is what we have to make sure we do. And we are all very concerned every time we hear these stories of what that looks like. But, I think there is an energy in getting it right. I think the employees that we hired from Western bring their own energy to it. They are still very grateful for all of what this board did with their board to make all that happen. So I do think there is.
Good.
Well, Vantage Point. Crisis Service Unit. Jenny, are you gonna talk about that a little bit?
Yes, I am, Brian. Thank you. I'm going to just share a little bit. We try every month to talk about crisis services and what we're doing with crisis services. I think clearly by some of the public comment and always in Jerry's comment, it really rings true for us that every month we should pay attention to what is going on with crisis services. How many of our consumers, our citizens, are in crisis, are in our EDs, are without service. So I like to try to remind this group that Smoky started more than a year ago our Crisis ED initiative. And it has grown. It has especially grown on October 1 with the addition of 8 counties. So it's a much bigger effort now than it was before. Just as a reminder to you, basically what this effort is about improving access to care. It is about preventing crisis. It is about managing crisis when it occurs away from the emergency departments, and whenever possible without using involuntary commitment and without using the highest levels of care, such as inpatient treatment. So globally, those are the goals that we're working on. We sort of divide those goals up into major areas of work, and I like to share with you when I can what we're doing in those areas. So we do a lot of community education and outreach and capacity building in the communities, trying on a local level to get stronger in these areas. So what we did most recently was law enforcement training in Haywood County, where we worked with the Sheriff's Department there to do specialized training. We did more involuntary commitment training this month in McDowell and in Haywood. And I would just share with you that this year, in 2013, we have trained more than 725 professionals. That's law enforcement officers, that's hospital staff, that's magistrates, clerks of court, mental health professionals. More than 725 people have been trained by Mark Fox and Angel Gray, and they are the leading experts in North Carolina on this topic. As a part of that training, we rolled out that consumer guide to IBC, to involuntary commitment, that I shared with you a month or so ago. And we continue to train on that guide as often as we can. We have a staff member tonight, Steve Michaels, is at the NAMI meeting in Rutherford County, using that consumer guide to involuntary commitment to help families and consumers understand more about prevention, more about ways of dealing with crisis other than doing the involuntary commitment process. We've also provided, just in the past 3 months, another 11 trainings in our communities focusing entirely on prevention, early intervention. As an example, we do the Darkness to Light training, Stewards of Children. This is training just members of the community about being aware, preventing exploitation and abuse of children. Every child who is abused will very, very likely be one of the adults who will be in our EDs, a decade or two from now. So this early intervention is very, very important. We continue to work on building relationships in the community. We do this primarily through our stakeholder committees. When we talked this time last year, we had 13 committees going across the 15 counties in Smoky. We're very excited and very proud. Well, today we have 23 committees going across 23 counties, and that big expansion really just happened in the last month or so. And I guess one thing I'd like to point out about that, it's very realistic to hear people in this room continue to ask us, if you get bigger, how will you stay local? And I think I would give you this as an example. These CEDI committees, these local stakeholder committees, these are in individual counties, and every one of them has Smoky staff facilitating, supporting, really driving the continuation of these committees and solving these problems on a very local level. So I hold that up as an example to you that size does not prevent local work. We can still do that. We're still working on managing our mobile crisis teams and our walk-in centers very well, and we did, after some additional technical work, we are now doing another kind of hard start on the metrics work. We have, and I think you're going to hear more about this in just a few minutes, we have implemented our comprehensive provider model for MCM teams and walk-in centers in the legacy Western Highlands counties. And I included a handout for you that lists who those providers are, where to find them. And just know that every person in crisis, or every person who has a friend or a minister or a loved one who's trying to support them in crisis, if they call our access line or if they call the mobile crisis number, they will be linked to service certainly within 2 hours. We very rarely have a more than 2-hour response time, and we most often have a 30-minute or less response time. So we just like to keep you aware that this is a really big issue for us. I think to close, I would point out that it's a national issue. It's certainly a statewide issue in North Carolina, and it has gotten more recent attention. You may have seen a recent press release about a statewide initiative on managing crisis, diverting away from EDs, improving access to care. So we at Smoky are hopeful about that initiative and hope that we can be a part of it. Thank you.
This is a really good segue tonight. The vantage point piece because it's about crisis services. And we chose this because one of the major, I would say most major change we made in Western Highlands counties as they came in was around the provider and the kind of resetting of how the program operates with mobile crisis, because of a lot of concerns about how that was working out in those counties. And of course, this is a very important, very difficult to deliver, very important service for folks. You hear a lot about it. So tonight, we thought we'd try to combine two things in one here. with inviting Sandy Fuchs and Jordan Simmons from RHA to come and do two things. To give us kind of a status report after, let's see, October and November, almost 2 months of operation, and tell us how that's going. And then to also talk about, we do this traditionally at the vantage point to just take a particular situation where somebody has used this service and how it turned out. So, Sandy and Gordon, however you want to proceed, go right ahead.
Great. Thank you for having us. We really appreciate it. My name is Sandy Fuchs. As Brian said, I'm the Vice President of Operations for the RHA Behavioral Health Services in RHA Smoky Mountain Center counties, which is the legacy Western Highlands counties and the Smoky Mountain Center Central region. Prior to the merger with Western Highlands, RHA was the comprehensive provider in the Smoky Mountain Center Central region. We did mobile crisis there as well. We do lots of services in the Western Highlands region, the newest being mobile crisis management. So I want to start with that, and I want to give you some data. I think you all should have this packet, this handout in your packet. And this gives you some information about the mobile crisis management services that we started as of October 1. And many things that Christina was saying about people learning their jobs and all of that, I was nodding quietly along back in the back there because although this was a much smaller scale, midnight of October 1st, we hit the ground running and I think have had quite a mini success since we started, and I'm real pleased with how that service is going. I'm going to run you through a little bit of this data, and then I am going to tell you about one particular event that we intervened in and did have a positive outcome. And so let's start at the top. And I apologize, some of these numbers didn't look so small when I was looking at them on my screen. But to start, you'll see there the consumers, the number of individuals served by county. So the graph is broken up by county, but what you'll notice is that the total number for the month of October was 320 individuals served. That means we were called, we went out, had an intervention with us, so 320 discrete individual people served. I tried to compare that to, well, how does that compare to what was happening? That was, I went to a few different sources to get some data, but if you look at the total number, so that's for all 11 counties, so that's the legacy Western Highlands counties and the 3 central region counties, Caldwell, Alexander, and McDowell. If you compare October's data to a monthly average previously of those other counties, we served an average, RHA in the central region, and the previous MCM provider in the Western Highlands area served an average of 210 individuals per month. So in the month of October, we saw a 34% increase in utilization of mobile crisis management. I don't yet have the data to know how November is stacking up, and also don't know exactly what might be driving that. I know that we did lots and lots of marketing efforts. Christina and Brian and I spent a lot of time together going to community forums all over the 8 Western Highlands counties, and we had newspaper ads and lots of other efforts, meetings with law enforcement, all kinds of community meetings. So maybe that has something to do with it. I'm not really sure. One of the things that we hope has some to do with it is we really changed the model of how mobile crisis management is provided in the legacy Western Highlands counties. And what we did was we moved from a model where most of the staff of the team were housed and lived physically in Buncombe County, and they would go out to the surrounding counties whenever they got a call, making sometimes counties not really willing to call. We moved to what we call a mini-team model. And so we have staff literally who live all over these 11 counties. And so we always have staff on call who live in the county where they're on call to serve. And so I believe, and I've seen actually certainly the evidence that counties are starting to say, well, okay, we'll talk with you. We'll start working on this. Law enforcement's more willing to participate with us. Magistrates are more willing to participate, with knowing that if we've got someone local, they're going to get there quicker than if they have to wait for someone to come from Asheville. So I hope that that's driving some of that, and I hope that we can continue to build on those successes. But so far, I think that it's really been positive. If you get out your reading glasses, you can probably see how your county stacks up if you represent one of these counties here. The interesting thing, I don't have the answer for it, we had an increase in numbers of individuals served in all of those counties, except for McDowell County, and those numbers were down a little bit. I'm not really sure. Maybe we should take that as a good thing, that there were fewer crises in McDowell. But otherwise, all of the counties in that 11 county region did have an increase in the numbers of people served. Some of this, as we go through, you can, for your information, looking at the age of the people we serve, really primarily an adult population, some children, adolescents, some geriatric, but primarily adults 18 to 64. The gender split, I haven't looked at this in prior months. It'll be interesting to see because when I look at our Neil Dobbins Center data, which is our facility-based crisis and detox facility that's here, almost always there's a preponderance of men in that facility. And so it's interesting to see this data compared to that. No idea what it means, but food for thought for sure. The next graph looks at the people we served and what the primary disability was. And this actually, as I was looking at this data, this is a piece I'm going to go back and take a further look at because these numbers show that we're intervening in very few cases with individuals that have intellectual and developmental disabilities. I'm not sure I trust these numbers. And so I'm going to dig into that a little deeper and make sure we're counting those. As a matter of fact, the person I want to present tonight has an intellectual and developmental disability, and so it's interesting that, was that really only one of 2 cases? I'm not sure. So I'll be looking at that further. But, preponderance of folks with mental health needs and then mental health and substance abuse needs. Next, we're looking at where we're serving people. 62% of the people we served in a community setting. Was really pleased to see that number because we are the primary responders for 4 hospital emergency rooms in this region. That's in Caldwell County, McDowell County, Mitchell County, and Transylvania County. So if they have someone in their hospital that has a psychiatric emergency, we're the ones going. And so really, as we incorporate in the Western Highlands area mobile crisis management to provide that service, as opposed to how it was previously provided, it gives us opportunities to really start intervening at an earlier level. It gives us an opportunity to work with law enforcement and magistrates and other people to say, why don't you call us before they get to the emergency department instead of once they get to the emergency department? So that's an area that we're really trying to focus is getting to folks before they get to the emergency room. And so it's our hope that we'll see those numbers go down and that we'll see fewer people in emergency rooms and more frequently in the community. Next graph shows referral sources. We get lots of referral sources. Of course, the highest number is still emergency departments. But you can see we get calls from Smokey. Carla's staff does a warm transport to our staff so we don't lose that consumer. They don't say, go, just call this number. They actually transfer the call and stay in the line until they're sure that the person's connected with us and is getting what they need. Other providers refer to us frequently, family members, people refer themselves very frequently. The next graph I think is a really important graph, and that's around response time. And that's one of the reasons we changed our staffing patterns. And even when we're regional, a lot of these counties, it takes a while to get wherever you're going. But I was pleased to see that 90% of our calls we responded in less than 60 minutes. And I feel like that's good out the gate. That's something we continue to always work on. Definitely we've noticed in the last 6 weeks that this service is a feast or famine service because it really seems like you've got everyone out in Buncombe and you've got everyone out in Rutherford and you still have the calls coming in, and when everyone gets back in, it's kind of quiet. So we wish we could regulate when the crises come in a little bit, but I think we're doing all right. The next graph shows the amount of time we spend with people. Mobile crisis service definition allows us to spend up to 8 hours really in that day trying to stabilize a person. Most of our interventions really probably fall in that 2 to 4 hour range. But there are times that we spend 6 to 8 hours with a person in the community. I can think of a couple of times, one time in particular in Transylvania County where the sheriff called us out and our worker came out and they really did everything they could possibly think of to maintain this person in the community. And they eventually still had to refer them to an inpatient setting, but really there was this kind of, tenacity and willingness on our staff's part to really kind of do whatever it takes. And they ended up spending a lot of hours with the person and still didn't do the diversion, but they're willing to put it in when it seems like, the time may result in someone staying home. And then finally on the last page, page 4, this graph shows where folks went after our intervention. And as you can see, 68% of the folks stayed in the community. Or in some cases went back to the community. Often a person we may intervene in the emergency department. We go, we do an assessment, we do some safety planning, we talk to family and other supports, and they're able to return home as opposed to going to a higher level of care. Yes, sir.
Do you look at the time of day? Does that vary at all? I'm on the emergency medical thing, and it's amazing how many ambulances have to go out during the day, and I'm just wondering if you're...
We do. Well, I don't have it tracked. What I do know is one of the other changes we made was we centralized a dispatch unit to serve these 11 counties, and we have to add another position in the daytime. It seems like the bulk of our calls probably are coming in between 10 and 4.
Same thing as the ambulance services.
Yeah, which was surprising, so it's interesting to hear you say that. So we're actually in the process of recruiting a peer support specialist to be a part of that team. So there'll be a dispatch team of a qualified professional and a peer support specialist on during those hours, 10 to 4.
And then, like same as you said, that helps you with staffing in the long run, knowing when you're going to need.
Right.
Of course, you can't plan any of this, but there are some trends sometimes as
Yes,
well.
absolutely. Absolutely, yes. Other questions?
To continue relative to this position, how many of those folks that are going back into a community setting, for example, are going back not because you think it's the best portion, best plan, but because of lack of facility-based crisis or lack of psychiatric beds and so forth?
I would say that really, in my experience in the emergency departments we're working in, if our staff, but then ultimately the physician thinks it's not safe, they're going to err on keeping that person in the emergency department until we have a disposition for them. And sometimes that ends up being a long time, but that's where we're going to err. If someone truly is not safe, based on our assessment and in collaboration with the medical staff, it's most likely that they're going to stay in that hospital setting until we can find something.
So you take let's see if I'm doing the math right here. You take the detox, the state hospital, facility-based, and community psychiatric unit, that looks like 3, 6, 9, 28% of the population roughly that's coming through mobile crisis is their disposition is ultimately outside the home through a community setting.
That's correct. That's correct. One of the, I think one of the other important factors and has been a really nice way to get some economies of scale at RHA is the way we've been able to link the mobile crisis services to the Neil Dobbin Center, which does the crisis stabilization and detox services. It's here in Asheville. And there are times when we're able to, we're pretty much full all of the time at this point, which is a good problem to have because, if we're going to pay for it, we want to be using it. But we are able, if we can intervene before the person gets to the hospital, we can often get them to that facility as opposed to having them to go to a hospital. We can accept a pretty high acuity, level of acuity in terms of what a person needs, as long as there's not really complicated medical needs and they're not violent, those sorts of things. We are able to manage some folks that are have some high psychiatric needs. And so we have our dispatch unit is actually physically located at Neil Dobbin Center. And so we share the medical staff for Neil Dobbin Center also work with the mobile crisis team. So we really have kind of tightened that up, and they're a real team working together. Other questions? Okay. So let me tell you, give you one little scenario. It was, I think my staff had a hard time coming up with asking for success stories, and it seemed like they were kind of shy about it. And I think probably, this is kind of just what they do. And so, I don't think they spend a lot of time thinking about individual success stories. So when I started, prodding them, I kind of got flooded with them. But I'm going to tell you about this one particular individual. This was actually on our second day in business. It was here in Buncombe County. And we got called to work with Tony. Tony's a 17-year-old. She had received services for a number of years. She'd previously been diagnosed as having attention deficit disorder and Asperger's disorder. And she'd been in the hospital previously. She spent a long period of time at the Murdoch Center. She'd had intensive in-home in the last year or so. Was currently receiving services from a private psychiatrist and been, kind of maintaining. So we get the call, Tony's mother calls our mobile crisis line, and apparently there had been some kind of situation. Mom calls and basically says, Tony's had a meltdown. They're in the car. Tony has a meltdown, bites her brother, and tries to jump out of the car. So mom stops the car. Tony gets out, won't get back in. Mom doesn't know what to do. Behaviors are starting to escalate. They're not communicating well. So mom calls mobile crisis. She called mobile crisis at 11:20. Our staff met Tony and her mom and brother at a park because that's where they were when Tony got out of the car. So Neil, one of our responders, came in, started assessing the situation, trying to figure out what was going on. Neil, fortunately, had had some experience working with individuals previously that had Asperger's, and so knew enough to really successfully intervene here. So he met with him at the park. He assessed what was going on, tried to figure out what was leading up to the crisis. And what he learned was Tony was upset because she was trying to find out from her mother. She had this feeling that her mother was going to send her away to an out-of-home placement, that she was looking to have her go out of the home again. And so she was asking her mom, and really she just wanted an answer. She wanted a yes or a no. And mom was saying, well, no, I don't think so. It's not something. So mom was answering, but mom wasn't giving the answer in a way that Tony could hear it. And so as Neil's assessing the situation and starts seeing, this really is just a communication breakdown. They really are not on the same wavelength. And so he starts pursuing that. He kind of works with mom, works with Tony, and mom finally says yes. Yeah. Yes, I am. Yeah. Thinking about the fact that maybe I need for you to be somewhere else right now. Exactly not the answer that Tony wanted to hear, but de-escalated the entire situation because she'd gotten the answer in a yes or no format, and that's all that she was looking to have. And so as soon as that happened, as soon as Neil was able to facilitate that conversation, Tony really, her demeanor changed. She became a participant in the crisis plan. Part of what we do in mobile crisis, we assess, but if someone's staying in the community, we're going to have, well, anytime really, we're going to have a crisis plan that everyone's agreeing to, and that we make sure that people are able to support, and the support's going to be in place. And so, Tony worked with us, mom worked with us, we developed a crisis plan, and really things came together. It was de-escalated to the point that they were able to get back in the car and go on with their day. Our staff, Neil, followed back up with family the next day. He connected them back to the provider that had been giving them the intensive in-home services most recently to get re-engaged with a level of care that was higher than just the psychiatric treatment that Tony was getting. Neil, as we always do, checked in the next day to make sure things were still going well, that there wasn't another crisis brewing. Things were stable at that point. And so really, in some ways, you know, it seems like if you look back on it, a really simple intervention, but I can just imagine being Tony's mom in that situation, being in this public place, this busy place, people all around, and not really knowing what to do with her child at this point in time. And so I think that, you know, Neil really, our responder, felt like, you know, this was, you know, he felt like he'd really done his job for the day because things were really able to de-escalate and kind of get back to normal for that family. So. And we have 319 other stories from October to tell you.
Only time for one tonight.
The one I was going to tell you, I was like, this is way too much, so I shortened it for you. Thank you for having us.
What our support services is, dealing with people when they're, you know, at their worst perhaps, or greatest need.
Now, if I understand correctly, besides being a comprehensive provider in the central region, you're just doing rural crisis Western Highlands, correct?
No, that's actually not correct. We were providing a pretty extensive array of services across the Western Highlands area. We're the comprehensive provider in Madison, Mitchell, and Yancey counties. And although we weren't called that under Western Highlands, we've pretty much been the main provider in town for a while now. We also are one of the largest providers of services here in Buncombe County. In addition to, we provide the whole continuum of outpatient services, psychiatric services, ACT team, community support team, the enhanced services for adults, as well as intensive in-home services for children. We provide the Neil Dobbin Center Crisis Stabilization Unit, residential treatment at the Mary Benson House, prevention services. That's where we come from. We also provide a wide array of jail diversion services. We work really closely with Buncombe County and work towards diverting people out of jail into treatment services when it's safe and effective to do so. And then we also do quite a few services in Rutherford County as well.
Thank you.
So
how many employees does that represent for you roughly in this area? It's okay.
That's a good question.
It's okay.
I would say several hundred. And that doesn't include our IDD services. We have a number of group homes in this area as well.
Thank you.
Thank you.
In the northern region, the local crisis, is that the neighborhood?
Next item we have on the agenda is the consent agenda. Does everyone have a chance to review those items?
Motion to approve.
Have a motion to approve, is there a second? Ed, second.
I do have a question. Was there an email that changed the vote number that was separate from what the printout is here? I just heard it was 13-11, it's just 12-11 to vote. We're talking about the approval of the October 24th Board of Directors minutes, right? And here it says 12-11, and that's how I thought it was, but I've been told there was an email that went out that was 13-11. But that may just be right. Okay, thanks. But that's all. Okay.
All in favor of the motion, say, for approving the consent agenda, say aye.
Aye.
Are there any other issues?
Rick, I'd just like to ask a question. Talking about the proposed reconstituted board, it was stated that so far, 14-1 in favor of the reconstituted board, yes, proposed reconstituted board. Of that, the remaining 8 counties, that's 15, the remaining 8 of the 23, how many of those 8 that have not yet voted have no representation on the proposed new board? Someone have that breakdown?
I don't know, figure it out. Hold on a second.
Well, I'm not sure how
There was there 7 that did not have representation, 7 or 8?
Here's what we got a tally here of all the yeses. But we don't have exactly the crux what you're asking for. But here's all the yeses: Alexander, Allegheny, Ash, Caldwell, Jackson, McDowell, Wilkes voted no. Buncombe, Henderson, Madison, Mitchell, Polk, Rutherford, Transylvania, Yancey. Those are all the yeses.
Looks like what was Watauga voted
I
no.
thought you said it's 14 to 1 in favor of.
I'm sorry, Watauga. I'm sorry, Watauga voted no.
Yeah, I don't think Wilkes voted on it.
No, well, I meant you talk about 2 different things. You're talking about the vote of the last meeting, correct?
No.
Okay.
Resolution by the county commissioner.
Okay.
Approval.
I thought you said 14 to 1 in favor of, which makes sense.
14, 1 opposed, 1 voted against.
Counties,
That's the
counties so
counties.
far,
Counties so far.
the counties that are voting on the slate.
I got you, but didn't you just say several, you gave several that voted no?
No.
Okay.
Watauga voted no. All the other ones I said voted
Okay.
yes.
Okay.
I think the confusion is the several you said voted no with the 11, 12 vote of this board to send those slated names to the county. So I think that's, okay.
I would like to add in discussion with my fellow southwestern counties. Some of those counties have no intention of bringing it up for a vote.
Why?
One of the counties said, not going to bring it up, the answer's going to be no. CB still here?
I'm here.
What did your folks do or say?
We've not met.
Okay. And I seem to remember that Ronnie Beal was not going to bring it up in his own county, and he's one of the ones who would be on the reconstituted board. Swain County, their county manager said he wasn't going to bring it up. So
If you look at the numbers, the central region has all approved it. All of the Western Highlands folks have approved it. 4 out of 5 counties, no, excuse me, 3 out of the 5 counties in the north have voted on it. 2 approved, 1 not approved. It's the western counties, only 1, Jackson, has voted on it, and approved it, and 7 have not. So it's not really tied to who got it. Back to Lynn's original question, it's not who has a seat on the proposed new board, it's.
Well, obviously, Watauga is the only one that does not have representation that is voted against it at the present time, correct? So, of those 14, can you not say, Michael, can you not tell from the,
Let's just go through it.
of those
Alexander,
14, how many
Yes.
have representation and they do not?
Allegheny. Yes. All right. Avery.
This is actual claim.
Avery's not voted.
Okay. Ash is a yes.
All 8 Western Highlands counties have voted. But
4 there.
Before those.
4.
So 4 voted for it, they don't have any there right off the bat. And McDowell.
Jackson, so we can see it. So of the others, each of them have a position on there. Pardon? The Western Highlands folks who have voted, 4 out of 8. But they all voted in the affirmative. But if you look at those 7 Western folks who have not, I'd have to pull my list here. So this is for this thing. In the west, you've got, I'm sorry. Macon would have a representative that hasn't voted. Also,
I think Jackson is the only one that has voted, Jackson County Commissioners. And if I remember correctly, Ronnie and I are the only two representing those far southwestern counties.
okay.
I voted no, but I'm talking to both sides, you had already talked to candidates.
Okay, we didn't have that yet.
You have voted. For those counties that don't and that vote, your vote will be contingent on what has voted, right? Somebody abstains from voting, and you have a, let's just a hypothetical 15-5 count, 15 carries, right?
Are there any other?
But does not the state statute state that every county must vote?
No, it doesn't.
Must have an opportunity to vote.
Must have an opportunity.
It really explicitly say either way.
Yeah.
Just the long and short of it. I'm not even determined that that's.
Shall approve. My argument, my position was, you got shall approve, what's the use of the vote?
The process for appointing members shall ensure participation from each of the constituent counties of multi-county board. So the process for, it's got to ensure participation. So you.
Well, if you continue to read the statute, it says about the approval from the county commissioners, yeah, it says shall.
Shall approve.
I think that the thinking in the general statute is, it's usually explicit when it says, it'll say a majority or all. So that's why this term doesn't really say.
Out there.
Yeah. That's, so you
I guess
can,
somebody will pay attention.
I guess you can decide what. Let me just tell you, I did get a email response back from Dave. It says letters with the lawyers, with Secretary pushing for a quick turnaround, we'll call you tomorrow.
Is there a motion to adjourn? Billy Kennedy, motion to adjourn, is there a second? All in favor,